Hello, everyone. Is everyone ready for our psychology symposium? Woohoo! Well, welcome everyone. My name is Dr. Kadamian Saini, and this is going to be our capstone psychology symposium. So this is going to be for our students who are currently taking our psychology capstone symposium here at EOU on campus. We do have 7 students who will be coming up here and doing a poster presentation on their research that they have been doing all term. This is going to be a literature review on what they have decided to do, and they have a variety of different topics. There will be one presentation that we'll be doing a forewarning. So if there are any little ears nearby, we will go ahead and let folks know that we are encouraging anyone who has little ears to go ahead and potentially leave the room or to go ahead and have any earphones on at that time due to the sensitivity and the adult nature of the conversation that we will have at that time. Do folks have any questions before we go ahead and get started? All right. So all 7 of our presenters are going to go ahead and start their presentations. We will go ahead and have the presenters go. They will do their presentation for about 8 to 10 minutes, followed by a Q&A for each of their posters, and then we'll move on to the next presenter. So without further ado, we'll go ahead and start with our first presenter.
Okay. Hi, my name is Akil Damazero, and today I'm going to be doing my topic around animal cruelty and to answer the question of why animal slaughter isn't considered animal cruelty. And so I'm going to start with the legal definitions of animal welfare, and that's going to be that it focuses on the treatment and use of animals in industries with research and to reduce the suffering overall, but not completely decrease using animals. And in contrast, animal rights is going to be the argument that animals are inherently not ours to use, and so they shouldn't be used at all. So um, and then I'm going to go into the species hierarchies, and that's going to be the research suggests the attitudes towards animal cruelty are influenced by perceptions of animal intelligence and moral worth. And the animal mind theory is one of the main topics that proposes that animals are perceived with lower processing cognitive abilities are viewed as occupying a lower position within the social hierarchy. And these perceptions are reinforced through different various marketing practices that are euphemisms. And so, for example, this could be describing cows as cattle and poultry, which is chickens. And so this could serve as a barrier between where the animal is coming from and the use of it. And so the influence of species hierarchies was demonstrated by Bradley et al. 2020 with they used the animal purpose questionnaire and it measured participants' ratings on the animal usage, and results indicated that males were more supportive of animal usage in agriculture compared to females. And so going into the speciesism, Kavola et al. 2018 did a study between measuring the social dominance scales with how one perceives a species within the hierarchy and along with their political beliefs and attitudes towards animals. And the results showed that participants who viewed animals as possessing, again, lower cognitive abilities showed that they were more likely to perceive them as commodities, so cattle compared to companions as pets. And this was further research with the SDO, the social dominance scale, that people are more likely to support the animal hierarchies in perceiving what's a commodity and what's a pet. And Sinclair et al. 2020 found associations between speciesism and being in the right-wing authoritism. And so this is characterized by more of a social preference for order and not changing social constructs. And so in the context of consuming animals, this could possibly contribute to why the research showed that those who were against consuming meat had not just were against it, but were anti like veganism or plant-based products. And so this further showed that there was some type of dissonance possibly, and challenging the animal usage instead of, um, sorry, cognitive dissonance may often involve denying the suffering of animals used for food, but rejecting um, the overall usage of the animal in the agriculture system. And so this may provide insight into why the species hierarchies are in place between these groups. And so the cognitive dissonance that's possibly between this view is the psychological factors that play a role in this perception. And so cognitive dissonance can be described as when someone, in the terms of consuming meat, is when they experience a disconnect in where the product is coming from. And so it conflicts with their moral values and beliefs. And so that creates a dissonance. And so that may, that is researched as the meat paradox, according to Leach et al. 2020. And so it further distances people from where their product is coming from and supports that commodities are further emphasized with euphemisms and where and the pet difference in the hierarchies. And so back to the gender differences and perceptions of animal cruelty. So the research that examines the gender differences suggests that males overall are more likely to be in support of using animals compared to females. And Bradley et al. 2020 found that males were more likely to agree overall with the usage of them. And the um, the gap that I was aiming to understand was the mediating factor between the cognitive dissonance between the genders. Um, and so overall, I found that there's multiple avenues between how social dominance plays a role in the species hierarchies and what one may perceive as a commodity versus a pet. And um, yeah, that's everything. Yes. Yes.
Hi, thank you. I found the cognitive dissonance side of this sort of really interesting. Um, and I was wondering if does it show then that like causing or generating the cognitive experience of cognitive dissonance, do people um, end up like leaning towards then not wanting to eat meat? Does that push them to that conclusion?
So actually the
And
research found the
okay.
opposite, which was really interesting.
Oh, okay.
Yeah, so people that it depended on the gender though.
Yeah.
So where females tend to show more like avoidance with the
hmm
information regarding the animals, what's going on, males tend to show they take more of a pro meat stance instead of just
Okay.
neutral and avoidance. Yeah.
Yeah.
So that's I don't know if that answers your question
Yeah, that
directly.
gets into a little bit. So people not so much changing. Sometimes they change their behavior. Mostly they just like update their beliefs sort of to match or sort of come down harder on those beliefs.
Yeah, yeah. Like
Gotcha.
when they're asked the question in
Yeah.
the research. Yeah.
Okay.
That's oh sorry.
Yeah. No, you're
Um,
good.
I I was curious about that too because if they're higher in the social dominance scale, they would possibly
hmm
answer differently because it was self-report. So that was one
Okay.
limitation that I saw. But the cognitive dissonance, in the terms of behavior, if that's what you're asking, like
hmm
if it reflects differently with how they eat meat.
Yeah. Because again, a lot of people don't always like, connect the reality to them, and so then they experience if you can confront them with that cognitive dissonance, if they actually change their behavior.
Yeah, so one of the studies I did read about was they gave a group some meat and the other ones some peanuts, I believe. It was some type of nut. And the group that ate the meat reported feeling less morally inclined to decrease their animal consumption versus the group that ate the nut.
Oh, interesting.
Yeah.
Yeah, and if I have time, do I have time? Okay, I was wondering if that intersected at all with the people who would not experience cognitive dissonance, like people who are actually raising animals, because there's, of course, people out there who are, lots of people, farmers, who are very aware of exactly where their food is coming from, and they're often eating their own animals directly.
Yeah, I think that comes with, so there was like the four ends of justification. And so I think that definitely plays a role in like the personal beliefs behind why
Gotcha.
so normal, natural, necessary. So I think
Okay.
they would probably fall into perceiving it as that. And
Yeah.
I think that's the interesting part behind the background that can play into it for sure. I don't know if that answered your question.
Yeah, good, thank you.
Sorry.
Thank you.
Hello, everyone. Can you guys hear me okay? My name is Candace Vaughn, and today I will be presenting my capstone project comparing established pharmacological treatments for bipolar disorder and emerging interventions such as ketamine and psychedelic-assisted therapies. To begin, it's important to understand what bipolar is. Bipolar disorder is a chronic mental health condition characterized by significant shifts in mood, energy, and behavior. These changes are much more severe than normal mood fluctuations. Individuals experience depressive episodes, which can involve sadness, hopelessness, fatigue, and even loss of interest in normal activities, difficulty concentrating, and sometimes even suicidal thoughts. Many individuals also experience mania, hypomania, which can involve unusual high energy, decreased need for sleep, rapid speech, involved impulsive decision making, and risky behaviors. Because bipolar disorder can significantly impact relationships, employment, education, and overall quality of life, effective treatment is essential. Let's explore the neurobiology of bipolar disorder. For many years, bipolar disorder has been viewed as simple chemical imbalance. Today, researchers understand it as being a disorder involving multiple brain systems. Several neurotransmitters, including dopamine, glutamate, and GABA, play important roles in regulating mood and behaviors. Researchers have also identified abnormalities in brain circuits involved in emotional regulation and evidence that inflammation may contribute to symptoms. Beyond being fun to say, another important concept is neuroplasticity, which is the brain's ability to form and recognize neural connections. Newer treatments are increasingly focused on improving neuroplasticity and brain functioning. Let's start with exploring established pharmacological treatments. Current treatment guidelines identify medication as the foundation of long-term bipolar management. Lithium remains one of the most effective mood stabilizers and is especially important because it reduces both relapse and suicide risk. However, it requires high monitoring because of the potential side risks like kidney issues and thyroid side effects. Lamotrigine, and sorry if I don't say these correctly, is a commonly used preventative depressive or prevents depressive episodes and long-term stability, but is less effective for treating mania. Atypical antipsychotics can help manage both mania and depressive symptoms. However, the side effects such as weight gain, sedation, decreased libido, and metabolic changes may affect treatment adherence. Overall, these medications have strongest scientific evidence and remain standard treatment for bipolar disorder. Okay, let's skip to the good part. Emerging treatments. Researchers are increasingly interested in treatments that target neuroplasticity. For example, ketamine has gained attention because of it can produce rapid antidepressant effects, often with hours or days. It appears to work by increasing glutamate activity and promoting new neural connections. Psychedelic assisted therapies, including psilocybin and ayahuasca, have also shown promising results in depression research and may increase neural flexibility and brain connectivity. However, much studies exclude people with bipolar disorder because of concerns that substances could trigger mania or mood destabilization. Despite these potential benefits, emerging treatments require a better understanding of safety and effectiveness. Comparing the safety of these, traditionally medications focus on long-term mood stabilization and relapse prevention. In contrast, ketamine and psychedelic therapies aim to produce rapid changes in the brain activity and neuroplasticity. Although these emerging approaches are promising, safety remains a major concern. Bipolar patients may be at risk for treatment emergent mania, and research still lacks sufficient long-term data. Because bipolar populations are often excluded, studies of the most of the research is needed for these treatments. Okay, because they're excluded, more research is needed. Sorry. Highlighting the importance of conducting further bipolar-specific research to better understand long-term safety, effectiveness, and clinical potential for these emerging treatments. In conclusion, bipolar disorder is a complex condition involving multiple biological systems rather than a simple chemical imbalance. Current evidence supports that medications as the most effective and safe long-term treatment options. However, emerging treatments such as ketamine and the psychedelic-assisted therapies may offer new possibilities through their effects on neuroplasticity, but additional bipolar research is definitely needed. Thank you, and I welcome any questions.
Sorry to hog the questions. I was like, I can think of something if no one else has questions. Do the so the emerging treatments have these benefits that they're faster and they target again the neuroplasticity, as you were saying? How do they vary on side effects? Are they like more side effects or fewer side effects?
That is a great question. In the topic and the perspective I was looking at targeting the bipolar aspect, it was more of the unknown, not having the ability to explain what's going to happen if they give this population these emerging treatments.
Okay, so we don't know yet what those side effects.
Because of what they do understand of these emerging treatments and then the mood destabilization, the emerging aspect of what bipolar is in the brain, I think it's opening up to that research and kind of understanding more of what that safety could look like, but it's still emerging.
Yeah. Is there any speculation on like long term? Like, are these things that you'd like take them once or twice and then have long term effects, or would they also be ones you'd need to take lifelong, do you think?
There's actually both options. It depends on which one you go with. Like ketamine, for example, there's options where you could use a lower dose of that every day versus going maybe 3 to 6 months and getting an infusion. And also the research showed that if you actually have that guided assistance afterwards was where the biggest change was coming.
Okay, cool.
And then bringing it back to the neuroplasticity was because if you had that support to look at it in a different way.
Thank you.
Thank you. Thank you.
Any other questions?
Hello, everybody. My name is Austin, and today I'll be talking about sports injury, resilience, athletic identity, and their relationship with returning to sport and pre-injury performance level. So as many of you might know, injuries are common occurrences in sports, and they affect athletes both physically and psychologically. When athletes sustain an injury, they experience a wide variety of emotions, cognitive stressors, and behavioral challenges. Many of the studies I focused on in my research explored anterior cruciate ligament injuries or ACL injuries. A lot of the research indicated that physical recovery by itself doesn't predict successful return to sport, but also that psychological readiness has a crucial influence on return to sport and recovery outcomes. So I want to note a difference between returning to sport after injury and returning to pre-injury level of performance. Many athletes don't recover from their injuries, but the ones that do might not be able to perform as well as they did before their injury. Previous research also indicated fear of re-injury, confidence, and self-efficacy also seem to be very influential factors. And lastly, I'll go over athletic identity as well and how that plays a role in the recovery process. So now that we've established recovery as multidimensional, both physical and psychological, we need to understand how athletes actually recover from their injuries. And that would be through their resilience. So researchers Sarkar and Fletcher define psychological resilience as the role of mental processes and behaviors in promoting personal assets and protecting an individual from the potential effect of negative stressors. So within the sports context, resilience can include emotion regulation, coping strategies, specifically cognitive reappraisal, which is essentially shifting one's thinking to be more positive, to make a difficult situation more manageable. Confidence building and rehabilitation adherence as well. Research on resilience after injury found that positive injury appraisal is associated with better emotional outcomes. So when someone's thinking positive about their injury situation, things like stress and anxiety are less. Athletes who view their injury as an obstacle to overcome show more recovery success. High confidence and self-efficacy also seem to improve recovery outcomes. Research also found that fear of re-injury is a huge, if not the biggest, barrier between an athlete returning to sport. And that's even when they had good knee function. So an athlete might properly physically recover, but because they're worrying about getting injured again, they don't actually return to playing sports. Psychological readiness also has shown to highly predict successful return to sport. A study by Zawolski et al. 2023 explored PPC and APC and their relationship with readiness to return to sport, where PPC is one's physical or perceived physical competence, so a belief in their body to complete a task, such as recovering from injury. And APC is their actual physical competence, and that would be the objective physical measures of their injury, such as their strength and their mobility and range of motion and things like that. So they found that the athlete's belief in their body predicts their readiness to return to sport, where their objective physical measures don't. So all of these studies together suggest that an athlete's mentality towards their injury situation and their belief in their ability to recover is very important for them to recover successfully. As I mentioned, returning to sport does not guarantee that someone returns to their pre-injury level of performance, but further research exploring return to performance found that psychological readiness to return to sport does strongly predict return to performance, as well as high confidence, a low fear of re-injury, and high self-efficacy. So these things suggest that when an athlete is prepared and not scared to return to sport, they have more successful recovery outcomes. And also that athletes might physically recover, but lack the readiness to return to sport confidently. Some of the studies exploring return to performance also included athletic identity and they discovered that high athletic identity and sport commitment are associated with return to pre-injury level of competition. And this leads me to my next section on athletic identity. Brewer et al. Define athletic identity as the degree to which an individual identifies with the athlete role. And in that article, they predict that a strong athletic identity might be both beneficial and harmful at the same time. Further research supports this by showing that a strong athletic identity might increase one's motivation, their rehab adherence, and their sport commitment. But it can also increase someone's emotional distress during injury and increase their vulnerability when they lose sports participation. So I wanted to explore permanent sports participation loss, and that would be identified as a career-ending injury. I found that these were associated with lower life satisfaction, depressive symptoms, and identity disruption. A separate study by Haslam and colleagues found or explored professional athletes retiring, and they found that multiple identities outside of sport appear to be protective during career transitions. So when athletes can find their self-worth in other identities, then they have a better psychological well-being when they're retiring from their sport. So these studies together support the idea and the prediction by Brewer that an exclusive athletic identity might be both beneficial and harmful at the same time, and depending on the context. Exploring these topics leads me to conclude that sports injury recovery is both a physical and psychological process, that psychological resilience plays a major role in successful recovery outcomes. Confidence, self-efficacy, and psychological readiness greatly influence return to sport and performance recovery. That athletic identity appears to function as both a protective factor and a psychological vulnerability factor. Also, that recovery outcomes should not be evaluated by physical measures alone. And lastly, that psychological assessment and support should be heavily integrated into rehabilitation programs. Doing my research on all of my articles, I noted that many of the studies focus specifically on ACL injuries, which makes it hard to generalize the results to other types of injuries. Several of the studies use small or limited demographics. Many of the findings were based on self-reported data where there can be participant errors in their reports. Also, athletes' experiences are highly individualized, so sometimes it makes these results hard to generalize. Many of the studies use cross-sectional designs, and that kind of limits the causal conclusions you can derive from the studies. Lastly, a lot of this research was qualitative, which includes things like interviews and self-reported data, and that overall reduces generalizability. So after all this, I feel like further research should explore the relationships between resilience, athletic identity, and injury recovery outcomes. It should investigate the effectiveness of psychological interventions during rehab. And further studies should focus on or include as many demographics as they can, such as age, gender, sport type, injury type, competition level, and also personality type. It would be ideal for further research to conduct longitudinal studies. However, those are very demanding. They require a lot of time and money. It should further examine career transition experiences in retired and retiring athletes. And lastly, it should investigate the methods for improving an athlete's psychological readiness to return to sport, as we see that it leads to more return to sport and return to performance. Thank you, guys. These are my references. You can scan the QR code, and I'll open the floor to questions.
Hi. Excuse me. Thank you. So I was wondering about the scenario where whether or not athletic identity and psychological readiness is not paired with physical readiness. Somebody tries to come back too early,
Yeah.
like because you believe that, oh, I can do it. How does that play into this idea?
Yeah. I personally didn't find any studies that explored that, but it seems like it could be very damaging for the athlete to return too early, especially physically, and that could bring down their psychological well-being a lot, probably.
Right. And I mean, that gets at the overconfidence, especially young athletes have with getting back to sport. Right. So they identify so strongly with a specific type of sport. They believe they can come back early, which often leads to re-injury.
Yeah.
That is both an internal, but it also can be externally driven by like a coach or a
Yeah.
trainer as well. Right. That can be very damaging. So I I think that that look at the early returners is because there are a lot of kids particularly who do that. So
Yeah.
it's an interesting idea.
Yeah, it definitely is. I didn't explore that exactly, but one of my references was a symposium of people like athletic trainers and physiotherapists and doctors and stuff like that. And they actually determined that a coach should not be involved in the decision for an athlete to return to sport, and that it should be those professionals that do that, because coaches have a lot of biases, like pushing an athlete to return to sport too quickly. So clearing for a return to sport should be determined by those people.
So I have a question regarding the return to play success. Do you see a difference between various age groups, such as like the Olympic athlete compared to the college athlete, compared to the high school athlete or the youth athlete?
Can you say the first part again? Just the return to sport?
Yeah, is there a different rate of success? Are they pretty much the same?
Um,
Um,
I investigated studies of all age groups, and so after doing that, those that competed professionally had typically higher athletic identity, and high athletic identity has been associated with more return to sport. So I can say that far. That's about all I can say for
that's
that.
kind of what I was leaning toward.
Yeah.
Yeah. Okay. Thank you.
All right. All right. Thank you, Austin. All right, for our next presentation, as I did mention, if we do have any young ears that happen to be nearby, please use your judgment, as the next presentation does have adult content.
Good afternoon, everybody. My name is Maggie Lindhorst, and I'm doing my capstone presentation on low libido. I chose this topic because it's very understudied. An example is like if you were to Google search low libido, like a Google search, or even like library and databases, typically they would come up with men's low libido rather than women's, and that's even in like general articles as well. With libido, it's the main focus is typically men's low libido. So I was like, this needs to be studied more, so I'm going to do some research on this. So to start, low libido or libido is the drive and desire around sex or the activities revolving around sex. So with low libido, this is having no interest in those activities or performing those activities. There's one disorder called female sexual interest arousal disorder in the DSM, and this is actually really the only disorder around female libido. So some of the criteria, and there needs to be at least 3 of these, to be diagnosed with this, and the woman has to experience some level of distress. If the woman doesn't experience distress, they're not going to get diagnosed. So at least 3 of these include reduced or no interest in sexual activity, reduced or no thought of or fantasies in the sexual regard, not initiating sex or a lowered amount compared to what they were before, no excitement during most sexual activities, no arousal to cues, and no genital sensations. So overall, there's really little information around low libido as it is in definitions. As I said before, this is really the only one that talks about low libido in the DSM. And this actually used to be labeled as hypoactive sexual desire disorder, but it changed to female sexual interest arousal disorder. I believe it was the DSM-4. So my main presentation is solely around the correlations and the treatment options. It can be a really broad topic, so I really just want to talk about like the factors that could be correlated with low libido and the treatments that are available. So there's some general demographics, reproductive health, relationship factors, mental health, medication, and problems around general health. I think my favorite subject out of all those was relationship factors, because it can have a really big role on their romantic relationships, their familial relationships. So the first one, or the first subtopic, was family attitudes around sex. So the way that you were brought up as a child and as a teen really can influence how you view sex. And it could also, you can have a poor relationship, like a poor relationship can affect low libido as well. And also, like if you're in a arranged marriage, so in cultures where arranged marriages are prevalent, you will see typically a lower libido in those women. But moving on to treatments, I found that a lot of these are just, as I said before, very understudied, and there's mixed results. So before I start going into these, I do want to say that these treatment options, it really depends on the woman and what the woman is going through. So some of these include testosterone, compassionate authenticity, eSense, which is like a platform women can use, emotionally focused therapy, education-based interventions, oral contraceptives, philbanserin, which is basically the female version of Viagra for men, and then cognitive behavioral therapy and couples therapy. And then there's also some other at-home techniques as well. The therapist might ask if they're doing therapy, they might ask them, oh, try these at home and see how they work for you. Some limitations I found when I was doing my research was, as I have said many times, there's just general limited research, and there should definitely be some more to come, I feel like, just to have more information. And then a lot of the articles only had one factor analysis. So they asked questions such as, oh, well, how does pain affect your libido, rather than why do you think you have low libido? And there's little to no LGBTQ plus population samples in the studies I found. A lot of my articles were straight women who were married or in straight relationships, and they were pretty long-term relationships. And then a question I had was, what comes first? Is it the low desire that comes first, or the factors, or is it the factors affecting the low libido, and is it a cycle? And then I also had a question on effective oral contraceptives. There is a lot of research on oral contraceptives, but some of them say that it's actually contributing to low libido, and others say it's actually helping women with low libido. So there definitely needs to be a little bit more research on that. And then also like the decade influence. So back at when like the sexual revolution was going on, what was the libido difference then compared to, let's say, like the COVID-19 pandemic? What's the libido difference there in people today? And there's also just a small number of diagnoses in the DSM. So further research, definitely more like bisexual and lesbian women population samples. As I said before, there was a lot of just straight women samples. And then also looking into the multiple factors of low libido assessment rather than that one factor I was talking about. And then also like cultural research on libido. I kind of talked about the arranged marriages. So topics such as that, how does that affect low libido? And then just more research on diagnoses. So in conclusion, low libido in women is very understudied, and there definitely needs to be more research articles around the different topics that I discussed. And then there's various treatment options available, and then for lots of further research needed on factors to help women overcome the distress of low libido. So that was my presentation. Thank you. I'll take any questions.
Hi, what a wonderful presentation. I
Thank
think this
you.
is such an awesome topic, especially given like our society's like disdain for women's pleasure. And this is not the most academic question ever, but what was your favorite part of researching this topic? Like any specific things that stood out to you that you really enjoyed learning about? Anything that surprised you?
Actually, I had a really interesting fact that I wasn't able to get to because, as you can see, my correlations are there's a lot of them. So lower income was a factor of low libido. And I kind of pondered it and wondered, well, why is that the case? And I was like, well, if a woman, let's say she's the head of the household and she has a lower income, she's probably more worried about making ends meet rather than, time with sexual needs and her desire. So her mind is more focused on maybe protecting her family and making sure that needs are getting met.
Awesome. Thank you so much.
Of course.
Did any of the research or diagnosis get into libido related to intercourse versus masturbation?
I think I remember like seeing some articles about that. It was definitely a little confusing. And since like this is so understudied, there was only like I had like probably 30 articles and maybe one or two addressed that. And they even talked about how masturbation might be better in cases like this, where maybe a woman is in a marriage and she isn't getting the needs that she is from her partner. So instead, she might need to fulfill that through masturbation. Does that answer your question?
Yeah.
Okay.
And again, there's limited research, so maybe this question gets even narrower. But does it get into the orgasm side of things and where orgasms are coming from? Because of course, there's clitoral versus vaginal orgasm. So I was
Right.
wondering if and maybe a little bit of sexual education coming in on that too. But
Yeah. I didn't see any research on that. I would definitely want to look into that a little bit more because there are definitely two different types of orgasms and definitely like the effects of that on libido. That would definitely be interesting. So that's a really good question.
thanks.
Any other questions?
All right, thank you.
Hey y'all. I'm Martha Calvillo Mendoza, and my capstone is about the mental and physical impacts of internalized racism in the US. So, to define internalized racism, it is an interpersonal form of racism that occurs within the individual. And this is the internalizing or endorsing of negative stereotypes associated with the individual's race. This typically comes from historical racism in which people hold on, in which people of different races other than white are dehumanized and segregated. And of course, this will lead to psychological distress, as in depression and anxiety. Sorry, chat. From racism related stress. Alongside psychological distress is physical health issues, as in cardiovascular health, high cortisol, and substance abuse, and etc. It would be so much stuff, actually. So to get into the history of it, it is well known that America has a long history of racism that has shaped and changed the way we treat certain people. So the exposure to racism can cause. Oh, wait a minute. I really have bad handwriting. So racism has shaped and changed the way we treat certain people. So the exposure to racism can cause an individual to internalize those comments and actions that society or family members have even uh, say to them. And this even includes friend groups that are within the same race. So, and this leads me into colorism, which is described as discrimination that privileges white skin and Eurocentric features over darker skin pigmentation and African features. This can affect work and everyday life because, you know, of course, you don't have as many opportunities as you would like just because the way you look. And these different features, oh, the want of these different features transferred to other generations. So this is known as transgenerational transmission. Along this, Gomez, one of the people, discussed cultural betrayal trauma theory, which is a contextualized framework of trauma within a minority, where the individual can be betrayed by a member whom they thought they could trust. And typically, I've noticed this as like parents or family members saying that you could look this way, you can act this way, and it's more Eurocentric behaviors or quote unquote white. And of course, that would affect your mental health, which can cause identity issues where the individual sees themselves as a threat to which they devalue, reject, stereotype, or discriminate against their own race and themselves, of course. Chan and Mendoza Diente, excuse me, view this as status-based rejection sensitivity, where the individual tends to expect discrimination and prejudice due to their stigmatized social category. And of course, to accommodate for this, individuals adopt American culture while ignoring their own. And at times, in-group people of culture, or what? In-group people of color will accuse others of acting white, quote unquote, because, yeah. And this is typically seen within college students who have internalized racism and don't relate to their ethnic identity. And of course, the ethnic identity would involve how much the individual associates themselves with their ethnic heritage. And this involves as in food, clothing, music. They might want to remove themselves from that and go towards the majority. And of course, this leads into physical health, so physical health will follow suit in the matter of coping with the hate. Hold on. or turn into severe health outcomes. An example would be high blood pressure and substance abuse. So something that is noted in Black Americans is they were likely to develop hypertension due to the interpersonal racism in clinical practices. So typically they are not given the care they needed and at times refuse to seek help in the fear of not being taken seriously. And another thing I would involve is a lot of people are embarrassed of showing their accent or what is it called? Showing their accent or looking different, or of course, not being taken seriously or thinking they have a higher pain tolerance in the medical field. So comparing both of these, all of this was approached through by, sorry about that, a biopsychosocial lens where racism is measured through daily stressors or a structure that the US is built upon. Racism is, oh, wait. Racism is measured through daily stressors or structure that the US is built upon. And racism is more than an action done by one person, but through a repeated system that places value on some more than others. Depending on the moderators, as seen through the chart, the moderators are basically the little identities one has. Depending on the moderators one has can determine the severity of their outcome. Another thing I wanted to include was the model minority myth, where positive stereotypes are enforced to a point where people feel the need to fulfill that stereotype. And that typically is towards people who are seen as hardworking or highly intelligent due to their race. And so they feel as if they can't complete that, they are not actually that race enough. And some further research and limitations. Pike had touched on cosmetic surgeries that are prevalent for seeming whiter. So, excuse me. This would include the following: hair straightening, skin lightening, rhinoplasty, and double eyelid surgery, just to appear whiter or just to seem whiter, basically. That's a thing I was really interested in seeing how aesthetic cosmetics are correlated to internalized racism. And as for limitations, I feel as if interviews provided more in-depth responses than surveys, although I do recognize that this is more time consuming and typically fewer people tend to participate. But I do really like in-person interviews because, of course, as I mentioned on the moderators, there's so many small things that can change the outcome of a person. To, like, as an example, a Black woman and a white man would have vastly different experiences. And also, if two people of the same race, gender, sexuality were in slightly different socioeconomic levels, there would still be a difference in how they are treated. So in conclusion, internalized racism can come from exposure to racism from family members, workplaces, or people's comments in daily life, where it can later be internalized as self-hatred for one's own race. And people with internalized racism tend to self-preserve or cope by either acting white, quote unquote, guys, substance abuse, risky behavior, etc. With these coping behaviors, there are negative outcomes to, negative outcomes to the quality of life, physical health, mental health, or a combination of all three. And for references, I do encourage you to look at the references, especially where I pulled this chart from. It's James 22, and he talks about the whole framework of internalized racism within the mental and physical. And I am open to questions, comments, or statements. Thank you very much.
What a wonderful presentation. I love this topic. So I think one of my main questions right now is how we differentiate the impacts of internalized racism versus the impacts of externalized racism, specifically in the healthcare field. Like, I know there's like a bunch of like poverty is one that's like, of course, you're not going to get access to healthcare, and many people of color have like the overlap is insane. So I was wondering how you differentiate those two, if you can.
Oh, I was like, Wait, just to reiterate, you mean the internalized and external
Yeah, how do
parts
we
of the medical?
differentiate the two? Like, how do we differentiate the effects of internalized racism from the effects of externalized racism?
I never looked too much into the medical field. I do know like a ton of stories of people assuming that they will not be taken seriously, but of course, there are people not stronger, people that acknowledge racism because of course there's certain things people say that are like, wait a minute, but I don't know, it's very subtle because nowadays racist comments are very subtle. They're not as outwardly as they used to be. So it's kind of hard to differentiate the two because, you know, if you have a lot of negative self-talk about yourself, it's really hard to know if it's real or not.
Thank you.
Thanks.
Okay. Did you notice if there was any gender differences and how it affected different, like, people of color versus like a man versus a woman?
Yeah.
Anything like that?
Yeah. There is this one article that does talk about colorism within genders, and it was seen that typically, and it was like a study about relationships where typically men will try to search for like a wider version of themselves, so like a slightly lighter skin tone than themselves. And of course, yeah, in the, you know, if you are a light-skinned woman, they would take you more seriously. And of course, the stereotypes of being aggressive or being delicate are there, and it goes the same for men. Yeah, that's what I've noticed. Of course. Oh, yay! Thank you. You did it.
Hi, everyone. My name is Jari Gray, and today I'll be presenting my poster on the relationship between motivation, self-confidence, and performance in soccer players. As both a soccer player and an aspiring coach, I've always been interested in why athletes with similar physical abilities can perform very differently. Two players can have similar speed, technical ability, and tactical knowledge, but one consistently performs better under pressure. That question led me to examine the psychological factors that contribute to soccer performance. Although most people think that performance comes down to the physical ability and technical skill and tactical knowledge, those things are obviously important, but the research suggests performance is much more complex. Throughout the studies I reviewed, motivation, self-confidence, cognitive skills, and coaching environments consistently emerged as important contributors to both performance and long-term athlete development. Before discussing the first theme, imagine a young soccer player named Alex. Alex has all the talent in the world and enjoys the game, but after a few difficult matches, his enthusiasm begins to fade. What keeps him coming back to training and continuing to improve? That question leads directly into the role of motivation, the first major theme. One finding that stood out was the difference between athletes who play because they genuinely enjoy improving and those who are more or motivated by primarily external rewards. The research consistently found that athletes who are intrinsically motivated tend to persist longer, remain more engaged in training, and continue developing over time. As a coach, this is important because motivation is not just about getting players to work hard today. It's about creating an environment where they continue to improve over months and years. Self-determination theory suggests athletes are most athletes are most confident when they feel competent, connected to others, and involved in their own development. In practical terms, players are more motivated when they feel trusted, supported, and capable. Now imagine Alex stayed committed to training. Over time, he starts seeing improvements in his game. He completes more passes, he's winning more challenges, and he begins to believe in himself. That growing belief introduces the next theme of self-confidence. In soccer, confidence affects everything from taking on defenders to making decisions under pressure. Research consistently shows that athletes with higher levels of self-efficacy or confidence in their abilities tend to perform more effectively in competitive situations. One thing I found interesting is that confidence is not something that all athletes are simply born with. Confidence can be developed. This research suggests that positive feedback, mastery experiences, and opportunities for success all contribute to confidence development. Players who experience success and receive constructive feedback are more likely to believe in their abilities and respond positively when challenges arise. Now picture Alex in a close game. With confidence growing, he receives the ball, quickly scans the field before making a key pass. In that moment, his success not only depends on his confidence, but also how effectively he processes information. This brings us to cognitive skills. And this was probably the most interesting part of the review for me because it directly connects psychology to what happens on the field. The research showed that elite players often demonstrate stronger cognitive skills, including executive functioning, decision-making, anticipation, and visual scanning. As soccer players, we're constantly processing information. We have to identify space, recognize defensive pressure, and make decisions in seconds. Studies on visual scanning showed that players who gather information before receiving the ball often made better decisions and perform more effectively. The research also highlighted self-talk as an important skill. Positive self-talk can improve confidence, focus, and resilience, particularly during high-pressure situations. As players, we've all experienced moments where our internal dialogue either helped us perform or made things worse. Alex's development did not happen on its own. Behind every training session, there was a coach who encouraged his effort, provided feedback, and created a positive atmosphere. That influence leads to the final major theme of my review, and that's the coaching environment. This emerged as one of the most consistent themes across the studies. Research suggests that coaches influence motivation, confidence, and athlete development through the environments that they create. From a coaching perspective, this means how we communicate with our athletes absolutely matters. Athletes in supportive, task-oriented environments tend to report higher motivation and greater enjoyment. They also tend to develop stronger confidence over time. One of my biggest takeaways from this was that coaching goes beyond teaching tactics and technical skill. Coaches also have to influence how athletes think, respond to challenges, and develop psychology throughout their careers. If we follow Alex's journey from a motivated player to a confident athlete to someone who's making better decisions on the field, we can see how all these factors connect. The connection is what this pyramid represents. When I put all these findings together, I started viewing them as a progression. And at the foundation of this is coaching. The coaches create the conditions that support athlete growth and development. That environment then influences the motivation, which affects how much effort, persistence, and engagement athletes demonstrate. As athletes continue training and improving, they begin to develop confidence through successful experiences and positive feedback. Confidence then supports cognitive performance by allowing athletes to make decisions more effectively and perform under pressure. Together, these factors overall boost soccer performance. And throughout the research, I found that these factors do not operate independently. Motivation, cognitive skills, and coaching environments all work together and influence one another throughout an athlete's development. So although my findings were generally consistent, there were several limitations. Many of the studies that I looked at relied on self-report measures, which they were just looking at how the athletes perceive themselves rather than directly measuring the athlete's behavior. And some studies also included athletes from multiple sports. So the studies weren't focusing exclusively on soccer players. Many of the studies were using correlational designs, which makes it kind of hard to establish a clear cause and effect. But looking ahead, I think future research could benefit from focusing more specifically on soccer populations and following athletes over a longer period of time. As both a player and an aspiring coach, I would be especially interested in research on how coaching behaviors influence motivation and confidence over the duration of an entire season. I would also like to see some research on practical coaching strategies that improve decision-making, resilience, confidence, and long-term player development. To conclude, the main takeaway from this review is that soccer involves much more than physical um, and technical ability. The research consistently showed that motivation, self-confidence, cognitive skills, and coaching environments all contribute to the athlete's development and performance. For coaches, this means developing players requires attention to both psychological and physical factors. By creating supportive environments and helping athletes build confidence, motivation, and decision-making skills, coaches can positively influence both performance and long-term success. Thank you, and I'm happy to hear any questions.
Thank you for running all around the room to supply questions. I just wanted to say I appreciate it. Thank you for this presentation. This is a really interesting, multifaceted approach. I was curious about the cognitive skills and was wondering if you had come across any research describing if these cognitive skills had to be highly domain specific, or if you could build up relevant cognitive skills for, like on the soccer field, in a video game, or somewhere off the field, if it would translate to a degree. Any ideas about that?
Yeah, so I don't know how it would translate anywhere else, but as far as soccer is concerned, there's things that can be taught in training. Like, for example, scanning before you receive the ball. That's something I spoke about. The more information that a player can take in before receiving the ball, then it allows him to execute and make decisions more effectively. And confidence is what then allows that athlete to make the right decision, I guess, when it comes time.
I have another question, but I
Yeah.
don't want to hog it if anyone else has one. Okay, I'll go. Thank you. So if you were to craft an intervention for coaches to promote these factors that you've deemed as like valuable for performance, what would that intervention look like for coaching and training?
Well, I mean, if you look at the landscape of soccer in the United States, we're pretty far behind every other country, which I think is pretty alarming since it's the world's biggest sport. But as far as like going in and getting coaches to change, I think first it starts with not and falling in love with just winning. A lot of coaches just want to win, and that doesn't do much for athlete development. I think putting athletes in situations where they're going to be successful, but also requires them to think, and then starts that then gets the train rolling of how can I read the game better? How's my anticipation? But I think coaches have to start in and stop just looking for wins. And how can we build our athletes to be more confident, more motivated, so they stay consistent, and hopefully the landscape of soccer in the United States can change. Anything else? Thank you.
Hello. My name is Carrie Jensen, and I'm going to be talking about atypical anorexia nervosa and anorexia nervosa. Before I start, I'm going to define a few terms. So first off, morbidity or just morbid in this context refers to disorders. So if I say something is premorbid, that means it happened before the development of the disorder. If I say something is comorbid, that means that usually it's like symptoms of another disorder that are happening while someone has like one disorder. We also have the anorexias. So first off, we have anorexia nervosa. This is a disorder with its own diagnostic code. It is usually, so sorry, I just lost my train of thought. It is usually characterized by not eating or very restricted eating and a like severe averseness to gaining weight. And it has some severity indicators that add a weight requirement onto the diagnosis, because when you're diagnosed with anorexia nervosa, you have to also have a severity indicator. So you might be diagnosed with severe anorexia or mild anorexia. And so the severity indicators mean that if you are going to be diagnosed with anorexia nervosa, you have to be at the highest BMI level, 17 kilograms per meter square, which is in the underweight category. Atypical anorexia is for anyone who would otherwise have fit into the anorexia nervosa qualifications, but don't qualify for anorexia nervosa because their BMI is too high. So there is a problem with this because anore- a- atypical anorexia is not within it's not its own diagnostic category. It shares a diagnostic code with a bunch of other disorders that are pretty much just like, for instance, bulimia that doesn't hit all of the actual diagnostic criteria for actual bulimia nervosa. So they would get like the bulimia in the other specified feeding and eating disorders category, and the other specified and feeding eating disorders category has one diagnostic criteria, and everything within it goes in there, and that includes atypical anorexia. And because of that, it is relatively lesser known, which is a problem when it's combined with weight stigma, because of course people who have atypical anorexia are going to be fatter than people who have anorexia nervosa. So there is, when it comes to clinicians, there is a hesitance to diagnose or treat because they are not as aware of atypical anorexia. And because of the weight stigma, assuming that you can only, if you're going to have that kind of eating disorder where you're not eating, then there's the assumption that you have to be thin, which is problematic because you don't have to be thin to commit suicide or develop an endocrine disorder. And in a study found that when it comes to anorexia, those are two of the highest fatality for early fatality is endocrine disorders and suicide. So also, furthermore, treatment generally assumes thinness. So if someone with atypical anorexia is given a feeding program, which is essentially just trying to help them bulk up, because that's very important when you're trying to recover from anorexia, is gaining back some of the weight that you've lost. In the refeeding treatments, the caloric requirements, even considered high, were not enough to properly refeed people with atypical anorexia. So anorexia nervosa and atypical anorexia are also very similar. It's just the weight requirement that differentiates them. So they're very similar in comorbidities. They are very similar in symptom severity. They're very similar a lot of the times in treatment duration. They are very, very similar. If there is one difference, it's probably that atypical anorexia does have higher severity in terms of symptomology. And the solution to this, quite frankly, would just be to either completely get rid of the BMI requirements or just combine the two diagnoses. Because I think if the two diagnoses were combined, then that could help just convince people that it's not just a thin people thing. It's also, it could happen to anyone, which is especially important because, as you can see by my figure, if you are obese or overweight in terms of BMI, you're less likely to be diagnosed with any restrictive eating disorder. So that means you could be obese and just fully stop eating, and there's a pretty decent chance that you're not going to be diagnosed with anything until you become, quote unquote, like the healthy weight. So yeah, as you can see, thank God you're losing weight. That's probably what you're going to be told by your doctor. So there are many also, I talked about severity. The indicators for severity for anorexia nervosa, they don't actually really measure anything. Because severity specifically looks at how severe the symptoms are, and they couldn't find anything. When multiple studies were made, they could not find anything. So there are some limits in that most of the studies have been done on a Western population, and they've mostly been done on white women who were hospitalized. And to be hospitalized, you generally need some kind of money. Even if you are in a country that offers free healthcare, you'll need some money to afford taking the time off. You'll need some money to afford just, again, just taking the time off, the caretakers, all of that. Also, furthermore, a lot of the sample sizes were small, which is kind of to be expected in a lot of mental health, like disorder type of studies, but it still could be improved. And further research definitely needs to be done into more diverse groups, just to be sure that all this information carries on to other groups. But yeah, I hope that wasn't too boring. I will open the floor to questions if anyone has any.
So I was just wondering, with the symptoms being similar, is there a difference in mortality rates between those that were diagnosed with anorexia and versus atypical anorexia? Or were those also like similar rates?
I tried my hardest to find any study that looked at mortality rates for people with atypical anorexia, and I could not find any.
Okay.
So that is also something that needs further research.
Thank you.
However, if I had to measure a guess, I would say I don't think there's gonna be much of a difference, if any, just because, quite frankly, any amount of weight loss can be kind of unhealthy. Even if you're losing weight completely healthily, you're going to lose some bone density. And that's not even talking about the very rapid weight loss, as well as the many, many methods to lose weight rapidly. They come with their own health risks. And actually, an article that I read had this one quote that I really, really love. And it said, like, there is an overemphasis on the health risks of being obese or overweight, and there is an underemphasis, if even mentioned, of the health risks of losing weight.
Hello. I also have a question. Would you say that I guess the way individuals who may be heavier are viewed differently compared to people who aren't? Do you think that this entire issue is socially constructed, or do you think it's something else that's causing it?
I think I think a lot of it is socially constructed, because while being obese can come with its own health risks, so can being underweight, and yet there's a very much a preference towards being underweight, especially in this society. So I think if we removed the like social stigma, I don't think there'd be any if there's any difference, I don't think it'd be that big between like everything. I don't know if that made any sense.
I agree.
Okay.
Do you have any thoughts for what would be a better way to measure what someone's healthy weight is than the BMI?
I would honestly say when it comes, because healthy weight it really depends on the person. So I would say probably look at, how they're feeling generally. And then it would just have to be something like a full like medical workup, essentially. So check for signs of malnutrition versus like check for warning signs of health complications from like obesity, and as well as like quality of life and how they are able to sort of get around, and as well as probably, quite frankly, like just their lifestyle. Like, are they eating foods with like enough vitamins and minerals to nourish their body? Are they exercising semi-regularly? That kind of stuff. It's as much as I would like it to be, it is not as simple as just like a BMI. It's going to be a very big, complicated thing.
Sorry, I also had another one. You mentioned about the different like ways that we have now to make it easier to lose weight. Did
Mhm.
you find anything in your research, like any papers that specifically talked about anorexia with using medications like Ozempic that's going around?
Not for specifically Ozempic, but yes, I did. And uh for like other medications, and it mentioned that yeah, there are a lot of health complications when it comes to that. And it described people, unfortunately, one of the medications I looked at, I can't remember the name, but it increased your risk of heart attacks. And someone just took it for like not that long, I think 3 months, and then they just stopped and they still got a heart attack because the medication still had that kind of effect on their body that it just weakened their heart.
Thank you.
Thank you.
Okay, so kind of a weird question, but
Uh-huh. Sorry, that's my sister.
you mentioned how there's like no studies on like I guess the dangers of atypical anorexia nervosa. If there were studies and it was found that just regular anorexia nervosa was like significantly more dangerous, would you still it's kind of two-pronged. Would you still think that they should be merged, or and if you do think that they should be merged, do you think that there should be like, I guess like a qualification or an asterisk kind of for there to be more concerned with the lower BMI?
I think if it was found that there was a very like significant mortality risk for anorexia and not a typical anorexia, I would not be campaigning so heavily for their. I mean, I'd be campaigning more like at that point. I would stop campaigning for them to be combined and start campaigning more so for it to be more normalized for people, or at the very least more known that people like restrictive eating disorders happen no matter the weight. So to answer your question, if there is that kind of very significant difference, especially in mortality, then I wouldn't want to change the I would want the severity indicators to be removed, but I wouldn't like be like, oh, like I wouldn't be campaigning for them to be different if there is that big difference or the same. What? I'm sorry.
Oh, we get it. Okay, thank you.
Uh-huh.
All right. So that concludes all of our student symposium. Can we have all of our students come down so we can do one big round of applause for all of them? So let's have one big round of applause. Woo! So this concludes the portion of our student symposium at this time. We'll be taking a brief intermission at this time. So if you would like to go ahead and stretch your legs for a brief moment, and please come back, we'll go ahead and do our Psi-Chi initiation and graduation. Thank you, everyone. All right, folks, we're going to go ahead and begin here in just a moment. If folks can go ahead and grab their seats. And if I can go ahead and have the psychology faculty join me up here in the front. I'm going to give you this now. Me? Yes.
Oh, I didn't plan any words. Uh-oh. So, yeah, I guess before we're getting started, Deanna is leaving at the end of this year, which is only like, whatever, yeah, 3 days away. So,
Wednesday.
yep. So, so we got a card and gift for you, and we're congratulating you on making it, not having to ever grade anything ever again.
Thank you so
Yeah.
much. So here's the card from all of us faculty. And, oh, Carrie, did you get it?
Yay! The printing didn't turn out great, but yes. Thank you. I like this one. The extra stripe body area. Yeah.
Thank you. I really appreciate that. Thank you all. I am going to so much miss my colleagues and my students. You all are awesome. I don't need to speak into the mic. But I really do. It's been a very fascinating 23 years. I don't know how many of y'all know that this is my alma mater. So I graduated from here in '88 of the previous millennium. This is sort of thing. And so, yes, I really appreciate it. I really am going to miss my colleagues. And I'm definitely going to miss my students. You, y'all. So take care and thank you so much. Thank you, Carrie. Bye. Yeah, you can go ahead and sit down. So without further ado, I'm going to go ahead and turn this over to our Psi Chi officers who are going to go ahead and start us with our induction for our spring cohort.
All right. Good evening, everyone. My name is Aspen Smith, and I am the current Psi Chi president. And I'm going to give a moment to my fellow officers to allow them to introduce themselves as well.
I'm Carrie Jensen. I'm the current secretary of Psi Chi, and I'm going to be graduating.
Hi, my name is Emma Burlingame. I am also graduating, and I am the current vice president.
Hi, I'm Megan Harris. You guys can see I took all my heels home because I'm leaving in a few weeks, so here we are. I'm Megan Harris. I'm the current treasurer, and I'm also graduating. So,
And I am also graduating. All right. We're going to start off this evening by inviting our new inductees to come down, and I have a bit of prose to give to you before we get to that. Here we go. Members of Psi Chi, your purpose in meeting here is to induct into Psi Chi the International Honor Society in Psychology. How many members do we have? 1, 2, 3, 4, 5, 6, 7, 8. 8 members who are earnest students in the field of psychology. Secretary, have these persons met the qualifications for membership in this society?
We have carefully examined the records of these candidates and recommend them to you because we believe they possess a vital interest in the science of psychology and show promise in the field.
You are about to be inducted into an organization that is international in scope, international in interests, and international in opportunities. Active members may hold office and vote on issues of societal importance to Psi Chi, as well as attend regional and society annual psychology conventions. By your presence, you have indicated a desire to be instructed in the purposes and ideals of Psi Chi. All right. If upon hearing these instructions, you still desire to join our fellowship, you will affirm your acceptance of the responsibilities of your membership and sign the EOU Psi Chi chapter roll. Miss Vice President, will you please instruct the candidates?
Before assuming membership in Psi Chi, we invite you to know the history and mission of the organization, its standards and ideals. The mission of Psi Chi is to recognize and promote excellence in the science and application of psychology. These aims are admirably summarized in the two Greek words psyche and kairos.
Psyche may suggest mind. Psyche may also suggest scholarship and enrichment of the mind. That this purpose shall be fulfilled, we have chosen as members those whose academic records are outstanding. If you are true to this ideal, you will strive to bring credit to Psi Chi in your academic work. Yet scholarship means more than the attainment of an honorable record. It demands that you not be content with merely adequate performance of the tasks required of you, but that you strive for real mastery of the subjects to which you are devoting your mind. The test of this is within yourself. Be satisfied only with the work well done, and finally, remember that true scholarship requires integrity.
Kairos, meaning hands, stands for fellowship and research. Herein lies the real test of your interest in this field. The word has its origin in fruitful fellowship. It is a culmination of careful scholarship. It does not require expensive apparatus and elaborate techniques, although these are sometimes of value, but rather it demands observation, logical thinking, and critical yet tolerant open-mindedness. If you follow these standards wherever you are and whatever your position, you will contribute your share to human progress. Our motto Psyche Kairos, may be expressed in these words: cooperation in the investigation and cultivation of the mind.
As future psychologists, you should acquire an attitude of tolerance toward those whose opinions or behavior differ from your own. One of the most fundamental teachings of psychology is the fact that individuals differ. This means that they have varying interests and motives and that they strive for different goals. You may look upon your science as a developing effort to understand human nature. As you grow in perspective, you will become more dissatisfied with the incompleteness of your science. This will be an indication of maturity. With respect to your association with the local chapter of Psi Chi, the members have the right to expect you to attend all meetings except when absence is unavoidable. Participate in programs when invited, further the cause of psychology on campus, and adopt the role of a loyal alumni in the years ahead. You have heard the aims and ideals of Psi Chi. Do you, as students in the field of psychology, accept its standards and purpose as your own? If so, say I do. Madam President, I recommend these candidates to you because I believe they possess a vital interest in the science of psychology and show promise by their academic records and by the pledges they just made.
Okay, you've signified your acceptance of the conditions of membership offered to you. Will you, to the best of your ability, elevate and advance the science of psychology, add to its share of knowledge, and assist in its search for truth? If so, say, I will. All right, now is the moment you're all waiting for. Culmination of this event. We're going to invite our inductees to come down one by one. All right. Inductee Catherine Crawford, come forward to receive the congratulations of your peers. All right. Honor is the reward of merit, which you already lit the candle. Because of your merit, you have earned the reward of honor. May this candle light your pathway as you seek your goal of academic excellence. Congratulations and welcome to Psi Chi. Okay, inductee Christina Hagan. Come forward to receive the congratulations of your peers. All right, honor. Honor is the reward of merit. Because of your merit, you have earned the reward of honor. May this candle light your pathway as you seek your goal of academic excellence. Congratulations and welcome to Psi Chi. Inductee Emily George, come forward to receive the congratulations of your peers. She is in absentia. Inductee Aurora Jones, in absentia. Inductee Shayla Surratt, I think is how you pronounce that. In absentia. In absentia. Inductee Maggie Lowe. Come forward to receive the congratulations of your peers. Right. Honor is the reward of merit. Because of your merit, you have earned the reward of honor. May this candle light your pathway as you seek your goal of academic excellence. Congratulations and welcome to Psi Chi. And then inductee Sarah Marin. In absentia. That's all we got. All right, one more round of applause for our new inductees.
Let's go ahead and take another round of applause and a picture for our new inductees. All righty. Thank you and congratulations. You can go ahead and have a seat. And I'll have you guys go ahead and stand to the side while I make a little announcement. All right. So we're doing a little segue to the agenda as I have a little special announcement that I would like to make as the faculty advisor of Psi Chi. So over the past year, we have done a lot for our chapter. We've really made ourselves a very active chapter, and the national office has taken recognition of this. They started following us on Instagram. They started noticing our accomplishments. They even recognized what we have done and even did give us a travel scholarship for 2 of our students, both our president and our treasurer, to go to Western Psychological Association, where they were able to present their research on brain rot. Yeah, it's definitely an interesting topic. But I do want to kind of share some interesting stuff that I want to kind of highlight that our chapter has done. So we became an active chapter since this was the first time our charter was created. We held our first initiation ceremony, which was done both in person and remotely, to include both our members and our community. We established our very first set of officers, which you see above for you right here. We partnered with our psychology club and held numerous guest speakers from all over the country. We did a huge recruitment effort both on campus by hanging Psi Chi specific flyers and doing a suicide awareness campaign on campus while partnering with local agencies and engaging in stressless events. We partnered with our local IPV and sexual assault center, Shelter from the Storm, and ran a month-long campaign on sexual assault awareness. Lastly, for a rural hybrid state university, we had 5 different presentations at Western Psychological Association this year. And as I mentioned, 2 of our students won the travel scholarship from Saikai. This was only just the beginning, folks. And I'm proud to actually announce that Saikai has actually named Eastern Oregon University as a model chapter award. And we have now gotten the recognition where we will actually be listed in the National Registry as a model chapter. We will also be getting a scholarship that we will also be getting as well as creating multiple different opportunities. And this is largely thanks to your officers right here. So let's give a huge, huge round of applause to your officers. So you guys can see that. You guys can put it over. Pretty cool, huh? Little secret I've been holding on for a couple of days. And as most people know, I'm not good at hanging on to secrets. So without further ado, I unfortunately have to say goodbye to my current set of officers and welcome a new set of officers. So I will go ahead and turn it back over to my officers as we start the new transition.
Okay, we welcome you to Saikai's Fellowship of Common Interest, Mutual Assistance, and High Endeavor. Members of the EOU chapter of Saikai, we are about to install in office those members of the group whom you have chosen to represent and lead you. The position of leadership is an honor, and along with any honor goes responsibility. Only the person who accepts the responsibility together with the honor is truly happy and effective as a leader. Faculty advisor has the group selected a treasurer.
It has.
I ask the treasurer of the chapter to come forward and to be installed in office.
Our treasurer is currently sick at this time. Sorry, my bad. My bad, sorry. Amara, please come forward.
All right, as treasurer, you are to pay out funds only on the order of the chapter. You are required to present to the chapter an annual report showing the amount on hand at the beginning of the year, the amount collected during the year, and the amount expended during the year on order of the chapter. To keep accurate records of these several items so that an accurate check can be made at any time by the chapter, and to assist the advisor with sending induction fees to the Saikai headquarters before induction takes place. Are you prepared to assume and to discharge these responsibilities?
I do.
The faculty advisor will now deliver to you the equipment of your office. Or I guess Megan, not the faculty advisor. I now declare you duly installed as the treasurer of the EOU chapter of Saikai. Faculty advisor, has the group selected a vice president?
It has.
I ask the vice president of the chapter to come forward to be installed in office. As vice president, you are required to be ready to assume duties of the regularly elected president in the absence of that officer. You are also to serve as program chairperson. As go the meetings, so goes the interest in the meetings. You are responsible for introducing speakers at meetings and for obtaining facilities for meetings. Are you prepared to assume and discharge these responsibilities?
I am.
Right. The previous vice president will now deliver to you the equipment of your office. Nice. I now declare you duly installed as the Vice President of the EOU chapter of Psi Chi.
You want to read the president? What? You want to read the president? Yeah. Faculty advisor, has the group selected a president?
It has.
I ask the president of the chapter to come forward to be installed in office. As president, you will find a detailed statement of your duties in Robert's Rules of Order. In general, you're expected to call the meetings to order, to preside at all meetings, to announce the business before the chapter, to preserve order and decorum, and to be familiar with the parliamentary procedure. The conduct, value, and contribution of Eastern Oregon University exhibited by this chapter rests upon your shoulders more than upon those of any other officer or member of this chapter. Are you prepared to assume and discharge these responsibilities?
I am.
The faculty advisor, the former president will now deliver you the equipment of your office. I now declare you duly installed as the president of the Eastern Oregon University chapter of Psi Chi. You are now officers of the Eastern Oregon University chapter of Psi Chi, and assuming the privileges and responsibilities of your offices, you are responsible for the chapter. Madam President, to you is entrusted the care of this chapter. When your term of office expires, you will entrust it to your successor, and so on down the line as long as the chapter exists. May the chapter always be guided by capable leaders. Since the officers have been invested with their duties of office, I put the meeting in the hands of the president, or more likely, a faculty advisor.
All right. Well, thank you, our former officers. You may go ahead and have a seat. And I will now go ahead and move it on to our now newly elected officers as we move on to our now graduation. Christina, who is our first graduate that will be going today?
Our first graduate is Jackie Lynn LaMarche. Jackie Lynn LaMarche from Richland, Washington, is graduating with a Bachelor of Science in Psychology. Through her online undergraduate studies at Eastern Oregon University, Jackie discovered a passion for trauma-focused work with underserved populations. Jackie will continue her academic journey at Walla Walla University, where she is pursuing her master's degree in clinical social work at Walla Walla University. Jackie is honored and grateful to be graduating member of Psi Chi, the International Honor Society in Psychology, and is very proud to stand alongside fellow students and professors who are committed to advocacy and mental health awareness. This milestone reflects her personal dedication and resilience, as well as the support of her loved ones and professors who have been instrumental throughout her journey.
Christina, who is our second graduate?
Our second graduate is Katie Crawford. Katie is a senior psychology major studying remotely from Springfield, Oregon. After many years working as an EMT, she returned to school full-time to pursue her passion for supporting individuals and families through some of life's most vulnerable moments. Her experiences in emergency medicine inspired her commitment to end-of-life care, grief support, and trauma-informed practice. Katie has been accepted into EOU's Master of Social Work program for the fall cohort, where she plans to focus on hospice and compassionate end-of-life services. She is grateful for this recognition and proud to celebrate alongside her peers today.
Lisa, who is our next graduate?
Our next graduate is Kristen Ortiz. Kristen is proud to be the first person in her family to be graduating from college. She is honored to be a member of Psi Chi and the EOU community and is passionate about continuing her education by pursuing a master's degree in the future. Kristen hopes to dedicate her career to protecting and supporting children and families through her work in the mental health field.
Okay, our next graduate is Maggie Lowe. Maggie was able to complete her education in 3 years with transferring schools and switching majors. Her favorite classes were psychopathology, personality, and human sexuality. She plans on going to mental health administration or human resources. Maggie would like to thank Dr. KDS, Dr. Colgan, and Dr. Jeffrey for the influence and support they gave to her during this memorable experience. She would also like to thank her husband, Aiden, who has supported her academic journey and achievements. Our next graduate is Megan Harris. Megan is a transfer student from Washington State. After graduating this year, she'll have her Bachelor's of Science in Psychology. She plans to continue her education by getting a master's degree in mental health counseling. Her ultimate goal is to be a mental health counselor for middle school age children. Yay! All right, Lisa, who is our next graduate?
Our next graduate is Carrie Jensen. Carrie Jensen served as the secretary of EOU's chapter of Psi Chi and Psychology Club, and as the co-president of Sage Club. He worked as a gallery attendant, a TA for the Rat Lab, and a psychology tutor.
Who is the next graduate?
Our next graduate is Emma Burlingame. In graduating summa cum laude, Emma is also a scholarship athlete and a considerate person. In addition to her success academically and athletically, Emma is a passionate musician who has performed as a member of the EOU Fiddle Ensemble. In the fall and in the UK, she'll begin her master's degree in sports and exercise psychology, carrying with her exclusive research experience from the Social Identity Lab. Emma has greatly enjoyed her time at EOU and is deeply gratified to be a member of Psi Chi.
Okay, Christina, who is our next graduate?
Our last, but certainly not least, graduate is Aspen Smith. Aspen is graduating this year with a bachelor's in psychology from EOU. She is also an executive board member of the EOU Psi Chi chapter. She would like to extend gratitude to her fellow board members for their heartfelt compassion, hard work, and dedication to trying something new as our chapter becomes an active force on campus. She would also like to thank her chapter advisor, Dr. KS, for taking on the extra next era of EOU's Psychi chapter and for showing the way when the next steps felt elusive. This year's team has done much with very little and will continue to grow in the path of excellence, service, and gratitude.
Well, let's give a big round of applause to all of our graduates. Congratulations to all of our graduates. And congratulations to our newly elected officers. I look forward to what we get to do next year as we continue on this wonderful tradition that we just started this year. Have a wonderful break, folks, a wonderful summer, and we will get ready to rock and roll in the fall, right? All right. Have a wonderful day, folks. Thank you all for sticking around. I almost forgot. Sorry, folks. Please stick around to celebrate with us with some sparkling cider. Come on, we need to celebrate, folks. Photographer, I've only had